morning. I'm glad to see that many of you did manage to wake up. Some of you probably wake up after waking up to here, but it's OK. After having a really exciting, very scientific session, the rest of the morning is to be pure clinics. But before I start, a friend of mine have sent me a few words of to make me feel better, some philosophical sentences that I like to share with you. It has nothing to do with dentistry, but maybe will feel all of us feel a little bit better. And these are rules to remember in life. So one of them is money cannot buy happiness, but it's much more comfortable to try on a Porsche than on a bicycle. The second one is to forgive your enemy, but definitely remember the bastard's name. If you help someone when they're in trouble, they will remember you when they're in trouble again. And very important, alcohol probably does not solve any problems, but neither does milk. And one thing that I like to add, always expect the unexpected. But unexpected can happen to us, not in daily life. It happened to us also in dentistry. And this slide I would call, before doing root canal, be careful what you're smoking. OK. So I hope I was able to revive a little bit. I want to thank MIS Company and the scientific committee for giving me the opportunity to be with you this morning. And I'll introduce a little bit the topic that we are going to discuss today. Well, we like to talk, we've seen it all day yesterday, we'll see it all day today, about value in implant dentistry. And when we're talking about value in implant dentistry, we say that our patients seek care for three reasons: to restore function, comfort, and aesthetics. So we are having an investigation, implant survival, that is indicative of success, but this is only statistics, because in real life, the survival of an implant is relevant if that implant is positioned in such a way as to prevent it functioning and the meaningful outcome of tooth replacement is not realized. So when we're talking about an optimal implant-supported restoration, and this is what we want, we're talking about four aspects that have to come together perfectly, which is the soft tissue envelope, the supporting bone, the implant position, and of course, last but definitely not least, the prosthesis contour. Well, in many cases, we expect and we achieve an acceptable result. Now, as I usually say in my lectures, I'm using the term acceptable result because we are mimic natures. We never produce something that's exactly similar to the original thing, but we are trying to do our best. Well, sometimes to achieve this such a kind of result is very easy. Guarded occlusion, good bone, good soft tissue, open small flap, place the implant, load it immediately, wait a little bit, prepare the final restoration, and we end up with a nice, acceptable result. But what do we do in these cases? How do we treat them, the more complex ones? Well, in these cases, we are talking about something that we call multidisciplinary treatment, which is multi-teams cooperation and multi-treatment procedures. Multi-team cooperation, it's a multitude of teams. It's a restorative team, surgical team, lab, orthodontic team, et cetera, et cetera. And of course, when talking about multi-treatment procedures, we have a large arsenal of procedures that we have to produce, they have to perform in order to achieve the result that we want. When talking about demanding situations in the aesthetic zone, we have basically 3 types of problems. One of them is teeth replacement in aesthetically challenging cases. The second type of problems is coping with ailing implants in the aesthetic zone. And the third one is the replacement of failed implants in the aesthetic zone. And just to explain, I'm going to show one case of each these types of problems. Teeth replacement in aesthetically challenging case. This is a very typical case. Young lady, central right incisor. This is what we have. We have you see already the gum problems, the spacing, the tooth is mobile, and we look at the X-ray and we see that the tooth is fractured. Now, the problems here are bone deficiency in apical location of the marginal gingiva, quite difficult to replace and restore in a thin and scallop biotype, highly plain, and a problematic soft tissue envelope if you want to perform a regenerative procedure. Because if you want to do a guided bone regeneration, we need space maintenance, we need complete and passive soft tissue coverage, and if you want to place the implant at the same stage, we need primary fixation of the implant. Now, at this situation, well, this is questionable, this is not achievable. So in this case, we have a teamwork, and we go for a treatment plan that will include several stages: orthodontics, bone regeneration, prosthesis, implant placement, implant exposure, and then the final restoration. And this is the team that has to work together. Now, what are the steps? The first one, always start with the prosthodontic analysis, and then the team works together trying to decide who does what and at which stage. And then we start with orthodontic forced eruption because we want more soft tissue, more corneal, and we know that this is a very predictable procedure to achieve more soft tissue over the future implant. A few months later, this is what we have. Now we have enough soft tissue to cover whatever we are going to do there. The tooth is a little bit more corneal, and this is the CAT scan. Well, of course, very little bone here, not much bone beyond the apex of the defect towards the nasal cavity. But at this stage, when we look at what we want, space maintenance, definitely yes. Complete and passive soft tissue coverage, possible because of the orthodontic manipulation. Implant primary fixation, not enough bone, not at this stage. So now it's the time for the surgical team, when we extract the tooth and perform a classical guided bone regeneration. This is what we have now. This is a defect. We see it's completely within the bone envelope, very easy to treat. We take our bone-free material. In this case, it's a mixture of demineralized and mineralized freeze-dry bone allograft. We can use a classical collagen membrane because all the defect is within the bone envelope, very easy to regenerate. Close down everything and wait. And now the patient goes back to the restorative team, which together with the dental technician will prepare some kind of interim restoration. And now we wait. 6 months later, we can place the implant because this is a soft tissue, this is the region that we have, and look at the CAT scan, we see that you have very nice, as expected, regenerated bone. Open a small flap. This is a new bone that we have there. You know, people are asking, is this bone? My good friend and a mentor, Professor Bill Becker from the US, used to say that if it looks like bone, if it feels like bone, if it smells like bone, it's probably bone. Very easy, take our C1 implant, place it in place, exactly where you want it for the future restoration, close down everything, definitely not immediately loading, and now the patient goes back to the restorative team for the new interim restoration. And wait again, another 4 to 6 months. And after this period, the patient goes back to the surgical team for the implant exposure. We expose the implant, perform some additional soft tissue enhancement, and refer the patient back again to the restorative team. because now they're going to prepare the temporal restoration and use it as a guidance device for soft tissue maturation. So this is the temporal crown that Professor Bicciaccio has prepared. And this is how it looks about 3 months after exposing the implant. And we wait a little bit longer. We want the soft tissue to mature completely. And then the dental technician and the prosthodontist are preparing the final prosthesis. This is the technical part. This is the final result. And as you can see, we can end up with an acceptable functional and aesthetic result. Another situation is coping with ailing implants in the aesthetic zone. Something that happens, complication happen, probably to all of us. This implant was placed by me a few years ago, and about 5 or 6 years after placing the implant, the patient came back with this situation. Swelling, pain, extensive bone loss, where the bone deficiency is extensive, but the implant is acceptably positioned, it's not mobile, and we have a nice, thick, soft tissue envelope around it. Again, we prepare the plan, remove the crown and abutment, regenerate bone, and then replace the final, the same restoration, the same crown and abutment. This is the teamwork. They always have to work with as a team in these cases. And the first stage, like always, is treatment planning. All 3 teams are sitting together to decide who does what, where, and how. And now, the first stage is for the restorative team to remove the crown and the abutment and prepare some kind of a interim restoration. The soft tissue is creeping up over the implant, and now we can go for the guided bone regeneration procedure. So open the flap. This is inflammatory, the site when we open the flap. We clean down everything mechanically, chemically, until we end up with this situation. And now we evaluate the case. Now, it may look a little bit extensive, but this is a case that's relatively easy to treat because we have very nice bone surrounding the implant. The implant is within the bone envelope, so we can basically cover up everything. So this is exactly what we do because we have space maintenance and possibility to fully cover the implant. So we take our bone film material, again, in this case, a mixture of demineralized and mineralized freeze-dry bone allografts. Take our barrier membrane. We prefer to use a longer membrane with a longer barrier effect. This case is also collagen. It's made in Israel. It's called the O61. And cover down with soft tissue everything, and wait. The patient goes back to the restorative team. They put back the interim restoration. And about 6 months later, we can open the flap again. Expose the implant. This is what we have. As we can see, the bone is almost fully regenerated. Do some soft tissue enhancement. Send the patient back to the restorative team, and now they will replace the original crown and abutment. This is how it looks about 1 year later. This picture was taken last week, 4 years post-op. Everything is stable and aesthetically and functionally acceptable. The third situation we have to cope with, it's when implants fail. I know it doesn't happen to anybody, just to me, but it happens. And this is the typical case. This lady has had an HA-coated implant, cylindrical implant placed about 16 years ago. And then she came to our office with this situation, pain, extensive suppuration, and we can see, of course, the bone loss. This implant cannot be saved. So we have a failing implant, bone deficiency, highly pliant, problematic soft tissue envelope, all the problems we can think of. This is the CAT scan, and we see there's basically no bone in the labial, very little bone on the palate. So treatment plan again, to extract, augment soft tissue, augment bone, place an implant, and then have the final restoration. When talking about failed sites, we have to remember that in the aesthetic zone, it's relatively more complicated to achieve an ideal, a perfect aesthetic result after failures of implants. But again, this is our teamwork. So the first stage, like always, is team treatment planning. All three teams are sitting together, decided who does what and when. And then is the time for the surgical team. Extract the implant and prepare some soft tissue augmentation. So this is the implant that we have. It's removed. We can see the missing bone. But we know that we need a lot of soft tissue coverage in the next stage in order to be able to perform guided bone regeneration. So we harvest a small piece of connective tissue from the palate and then perform a classical soft tissue interpositional graft. And this is how it looks like. We leave, of course, the connective tissue exposed. We know that it's going to heal and repitalize. Wait about 3 months. In the interim type period, Dr. Jacobi will prepare his temporary device. And now the patient comes back to the surgical team. At this stage, we're beginning to plan our guided bone regeneration. This is what we have clinically. It looks nice, but of course, it's empty. It's a shell, a very wide piece of connective tissue underneath that will provide us the coverage for the future GBR. This is the CAT scan, and if we look carefully, we see, of course, there's no bone here. But look at that. This is soft tissue. So when doing the guided bone regeneration, we're going to empty the surplus of connective tissue from inside, keep the tent of epithelium and about 1 to 2 millimeters of connective tissue, and this providing the space maintenance that we need. So this is what we have open the flap. This is the surplus of connective tissue that is going to be shaved out. And we evaluate the defect we see. We have very nice bone here and here. This will support the membrane. This will provide the osteocytes, the osteoblasts for the bone regeneration. So now we have space maintenance, complete and passive soft tissue coverage, of course, impossible to place an implant at this stage. So we start our classical GBR, again, our mixture of bone fill materials, and then adapt and prepare the membrane. This is a large defect. Long term, we'll need a non-resorbable membrane. This has to be, of course, very carefully fixed and adapted. Close down everything, and then refer the patient back to the restorative team for the interim restoration. And now we wait. We wait about 8 months. Because after 8 months, the patient comes back to the surgical team. This is what we have. Tissue looks nice, thick, and underneath, we have fully regenerated bone, as expected, of course. Nothing new here. Something we have been doing for more than 20 years now. Open the flap, remove the membrane. This is a newly formed bone. And at this stage, we can start preparing the site for our V3 implant. I personally today prefer to use the V3 because we know that the crestal bone is very, very fragile, not cortical at this stage, and probably the V3 will provide us a better maintenance of the crestal bone. So the V3 implant is in. Close on everything. Again, definitely not immediate loading. And now again, the restorative team is replacing the interim prosthesis. We wait another 6 months, and then expose an implant, perform some kind of additional soft tissue enhancement. And now is the time for the restorative team to prepare a temporary restoration and guide the soft tissue maturation. This is how it looks after 3 months. And a little bit later, the final restoration is prepared by the dental technician, of course, for the prosthodontist. And this is that we have at the end of the process. So when replacing missing teeth, the patient's expectations are, as said, to optimally restore function, comfort, and aesthetics. In implant dentistry, this ultimate goal is often within the reach of the treating team. But in many instances, in order to produce an optimal implant-supported restoration, a series of surgical, prosthodontic, technical, and other procedures are required. So we have today three very distinguished speakers. They are going to show how to optimally achieve implant-supported restorations.